do one wrap-up question on the Alzheimer's issue. I appreciate the conversation that's ongoing on this, and obviously this is one of multiple diseases that have a tremendous expense: diabetes, cancer, Alzheimer's, consuming a great deal of both financial cost and pain across the entire country. Last year, Congress passed the Alzheimer's Accountability Act, which required a report and to be able to get that budget estimate together, what it would take. When do you expect that to be complete?
So I appreciate the question. Yes, this was an act which got folded into the omnibus bill, which basically asks NIH to put forward what's called a bypass budget for Alzheimer's research, as we do now for cancer. And the instructions are such that we are to have the first version of that by sometime this summer in order for that to be applied to fiscal year 17.
Okay.
And we are on track to do that. I should say we will, in the next 24 hours, issue a new set of recommendations about Alzheimer's research based upon the summit that we held in February and the synthesis of those recommendations. So that'll be coming out tomorrow.
Terrific. Thank you. Senator, I'll look forward to going through that report. I'll be one of many. I'm like many people in this dais. I watched my grandmother do the long goodbye, and we've all walked through this. My mom currently has Parkinson's, and so we walked through this life together.
And Senator, if I may, because we had this conversation about Alzheimer's and AIDS, I would say that we've actually increased Alzheimer's spending since 2011 by 40%, more than any other disease in NIH's portfolio, specifically because of the scientific opportunities and the enormous public health need.
Thank you. Mr. Schatz had mentioned, and when Senator Schatz was talking about telemedicine, I want to reinforce some of the things that he's done there. Obviously, we have work to do with CMS on the billing process of that as well, but let me do one caveat in that. And this is not to belittle them at all, so I'm not going to just pick on somebody that's not here. The Census Bureau in 2010 spent $3 billion developing a handheld device to be able to do the census on, and at the end of it had to punt it. So we literally lost $3 billion with a B, dollars on a handheld device to take the census that eventually they went back to pen and paper on it. As much as we can use current technologies and allow the private sector to take the lead on that and to make requests of it, please continue to do that. I know NIH has done that a tremendous amount, but when we go into some of these other technologies, don't reinvent the wheel.
I'm totally with you. And in fact, for this precision medicine initiative, there's enormous interest from private sector developer of these various mHealth apps. We have no need, I think, to develop any of our own because they're champing at the bit to have theirs tried out in this kind of large-scale study.
Great. Thank you. Please press on with that. Let me ask a general question, a philosophical question. We've seen an increase in costs in drug and device development over the past several years. It seems to continue to accelerate without a cap on it. Can you help me understand what is driving the increased cost between basic research and clinical research all the way from the time of concept to the time of actually getting in the marketplace? What are the key factors that you see that's increasing the cost more than anything else? And I know it's not any one thing, but if you can give me a couple ideas here of what we should watch for, what's driving the cost change?
Well, a lot of it is the high failure rate, and that is, in fact, very troubling when you consider how rarely an idea about a new drug makes it all the way through to FDA approval. It's less than 1% of the time. And so all that cost of the failures has to be added into the overall enterprise. One of the things we're doing at NIH to try to help with this is the formation of the National Center for Advancing Translational Sciences, which aims to identify some of the places where failure happens, where bottlenecks occur, and develop new technologies in concert with the private sector to see what can be done about that. I mentioned this idea of human cells on a chip as a way of testing drug toxicity instead of using animals, and this is looking like it's maybe going to work, and that would be a big step forward as one of the places where things get balled up and don't work well. Another is this whole idea of precision medicine, where instead of trying to develop a blockbuster drug and finding it doesn't work when you apply it to thousands of people, you actually identify the subset of individuals for whom that drug is particularly well suited. You run a much smaller trial and you have a much better chance of success. So cost of the trial goes down and chance of success and ultimate FDA approval goes up. Those are all things that are in the works. But I share with you the concern we've got to turn that curve around, and we're all attentive.
Is there any one spot you identify these bottlenecks there? Is there any one spot that you see the cost increasing more than any other area as it goes from concept to actually distribution?
Boy, I guess the clinical trial, of course, is the most expensive part when you sort of look at where the dollars really start to build up. And if you have to do a clinical trial of thousands of people and follow them over a period of time, that is going to be very expensive. So we have to come up with ways to do smaller trials, to have biomarkers that allow you to know if the drug is working without waiting 4 or 5 years to see what's happened. Those efforts are really high priority.
Okay, thank you.
Mr. Kirk.